When you need medical help fast, use NHS 111 online to go from home to an urgent treatment centre.
Mr. Williams, please come through.
Or a pharmacy.
Hello, pharmacist will see you now.
Or if needed, stay where you are and get a call from a nurse, doctor or paramedic. Get assessed and directed to the right place for you in as little as 90 seconds. Use NHS 111 online.
This is the North East and North Cumbria Providers Podcast, highlighting the fantastic work taking place across the region to provide the highest quality of care.
Hi, and welcome to another episode of the Providers Podcast. I'm your host, Harry Newhouse, and I'm the communications support for the North East and North Cumbria Provider Collaborative. On today's episode, we're joined by Rachel O'Donnell and Michelle Russell, who are consultant gynaecologists at the Newcastle upon Tyne Hospital's NHS Foundation Trust. Rachel and Michelle are part of a regional NHS gynaecology network, and the network is supported by the Provider Collaborative and helps share best practice across the North East and North Cumbria. So let's welcome Rachel and Michelle to discuss this further. How are you both?
Great, thank you.
Very well, thanks.
Very good. We'll start with yourself, Rachel. Please could you introduce yourself and give us a brief overview of your career so far within the NHS?
No problem. Well, I'm actually a Geordie myself, so I was born here in Whitley Bay, and then on my travels I went off to Edinburgh, where I did my undergraduate training and actually the vast majority of my postgraduate obs and gynae training as well. I returned to the North East back in 2011 to do a PhD in some cancer biology work, and then I've spent the last number of years doing various posts around the region, looking after women with cancer. And then I joined the team here in the RVI in 2020, where I've been ever since, and delighted to be contributing to the service here as gynae lead.
Brilliant. And same question to you, Michelle.
So I'm definitely not Geordie, I'm proper foreign, coming from South Africa, and I did my medical training in South Africa, but then came over to the UK to experience the NHS and see something different, and unfortunately it never got rid of me, so I'm still here. I've been a consultant gynaecologist in the RVI for the past 12 years, and after completing my specialty training in the region, so I've stayed in the region pretty much since I arrived in the country. I'm a minimal access surgeon by trade, and the areas that I particularly focus on are endometriosis and other benign conditions like fibroids, but I also contribute to the cancer service. I've held a number of leadership roles within the department, and I'm currently clinical director of the Women's Service. I've always been interested in driving efficiency and improving service and access for patients, and I've contributed to a number of GIRFT initiatives and publications. And when I became a consultant, each trust worked in isolation, and there was no kind of sharing of ideas or initiatives. It seemed to be a rather competitive market. But since the COVID pandemic, the tide has definitely changed, and the NHS is moving in a more collaborative way with sharing of ideas, pathways and efficiencies in order for us to survive in the future, I think.
Yeah.
And what made you come to the North East and North Cumbria?
Was it the weather?
Definitely the weather. Truthfully, it was a Christmas night out. I'll leave the rest to your imagination.
That's how all good stories start.
Brilliant. Please could you tell us a bit about the gynaecology network that you were both part of?
So the North East and North Cumbria Provider Collaborative is a collaboration of 11 foundation trusts in the region, and it's a platform to share ideas and address the challenges as a group rather than in isolation. The ultimate aim is ultimately to provide the best possible outcomes and access for our patients. So we know that in gynaecology, the waiting list for first appointments and surgery had started to rise significantly pre-2019, but this was made significantly worse during the COVID pandemic. And when things were finally starting to return to normal service and hospitals opened for elective work, the waiting list was staggering, and the long waiters for treatment felt, I would say, pretty much insurmountable at that point. So we realised that the old ways of working were not going to be sufficient to address the backlog and to keep up with the demand. So it was important for the NHS as a whole to look at ways of working more efficiently, smartly to address the access for patients. So the network has enabled sharing of smart working practice and making data visible and accessible for trusts to use as a barometer to move in the right direction. But as a region, we realised that the value and the time saved in not reinventing the wheel or working in silos is where the value lies with the collaborative, and this will ultimately result in good patient care. So we meet as a group on a quarterly basis where we selectively look at data and present the associated key priorities that we have with these. And if a trust is doing particularly well in an area, then we ask them to share their pathways and to share their ways of working to see if we can adopt some of these as well.
How do networks across our region benefit patients, staff and the NHS in general?
So I've set my prime goal as chair of the Gynae Alliance is to have a platform and open forum to speak about the challenges, the frustrations and the blockers to improving healthcare for women. The figuring out as a group is what the enablers are, and if the Alliance can help move that forward, then it's a win-win for everyone, but particularly the patients.
You both work at the Newcastle upon Tyne Hospital's NHS Foundation Trust, and the department have recently had a visit from GIRFT, which is getting it right first time. What is GIRFT and what was the purpose of the visit?
So it's always a little bit intimidating when sort of national groups come into your department to have a look, but actually we really felt that this was a great opportunity for us. We knew we'd been working hard to centralise, the importance of care for each individual woman, and it really gave us a chance to interrogate what we do and to pick out the good bits and to think hard about things that we find challenging. So getting it right first time is exactly what it says on the tin. The excess referral rate in comparison to the capacity that all of the trusts have, there's always an excess of demand. And that therefore means that in order to get those women the right care, we need those women to move through the investigations, the management options as quickly and as efficiently as we can so that they get the care that they need. So it's about making sure that each patient gets the right care at the right time by the best person who can deliver that, which isn't always a doctor, and making sure that we do that consistently and fairly for everybody. So when GIRFT came to pay us a visit, I guess we started by talking them through what the patient journey is for the Newcastle region. So of course, most women will access care through their GP. And so what's great about what's happening in the collaborative within Newcastle at the minute is how this trust are trying their best to work with primary care to keep that conversation flowing so that we are more of a joined up team. In fact, we're quite looking forward to an event that the trust have set up with primary care in April later this year, where it'll be what can only be described as a speed dating event where various GPs will come and be able to talk with consultant specialists, about challenges and difficulties that they have. So we're looking forward to that, and there's more of that work to come. But really, from the point of referral, the GP will send in an electronic letter, and we want to make sure that we triage that person into the correct clinic. In order to do that, we had to do quite a big change to the infrastructure of our department. So we sat down as a group and sort of problem solved that. And we ended up turning it into what we call a hot week consultant. So each of us rotate through the position of being the hot week consultant or the on-call consultant. And during that time, of course, we're delivering great care to the women and the patients who come to see us as emergencies and such like. But we're also investing in our time and getting that paperwork trail correct. So actually, we can now triage all referrals that come into our unit, certainly within 48 hours of them arriving. And that means that they're in the correct waiting list pile. We do appreciate that the waiting list, is not necessarily as short as we would like it to be. So we're trying to now use that time for those people. So where it's obvious that that person is going to require, for example, a blood test or a scan, well, we're making sure that we communicate that back to the patient and the GP so that whilst they're waiting, they're using that time efficiently to get those results. And that means that when that woman arrives into the clinic where there is a decision maker to meet with them, they get a thorough evaluation, but they're also much more likely to be in a position where they can make a joint decision about what next steps are in terms of care. And that's hopefully reducing our follow-up rate, but also maximising the speed at which we get women to their treatment, whether that's a medication or even an operation. So that's just some of the stuff that we've been doing. I guess once our women are here and waiting, for operations and such like, it's about making sure that we bring together a collaborative team of people. Sometimes that's more than one specialist, so that we can efficiently deliver great quality care when they're here. One of the other ways in which we like to be able to collaborate with our GPs is through a working dialogue. Now, it's difficult for GPs to take the time to pick up the phone, to wait to speak to somebody who may or may not be available to speak to them. So that's where we've really invested time and effort in our advice and guidance service, which is like an electronic referral system where GPs can fire in a little question or a query about a patient. And again, we're using our Hot Week consultant as the person who can respond to that, usually within 24, 48 hours, so that where it's possible to deliver care within primary care, the GPs feel enabled to do so. And hopefully that ongoing dialogue will help our GPs in the region to feel confident delivering care for certain gynecological conditions without the woman needing to come up to hospital. As Michelle mentioned before, trying to get this all right for the patients, and we're dealing with a huge volume of patients here in Newcastle, is actually about us as clinicians uncomfortably stepping into other roles and working with our admin team as well as our managerial team and IT to try and understand and unpick the flow of patients and where efficiencies can be made. Now, we try our best to reduce unnecessary follow-up. That's an unnecessary burden for our patients, for transport, for days off work and such like, but also sometimes it can be an inefficient use of an NHS resource. So actually having conversations with our patients and moving them on to what we call PIFU, which stands for Patient Initiated Follow-up, can be really quite fruitful for both patients and the NHS and our department. That means that patients can still reach out and contact us directly if there is a problem or a query during their follow-up period, but also that they don't need to be troubled with coming in and out of hospital if there isn't a problem that requires immediate addressing. And that's been really successful in gynae. We're starting to see our PIFU numbers slowly rise, which means that we're freeing up capacity for new patients to come in and see the specialists. It's also really great to acknowledge that the gynaecology team here isn't just a set of doctors. We've got a huge number of very specialist nurses. We work with physiotherapy, we work with physician associates, etc. We work with other specialty areas within the hospital. And actually sometimes utilising the wider multidisciplinary team, in particular our nurse specialists, means that patients get better care quicker.
So what steps were taken ahead of the visit and what feedback did the department receive?
So ahead of the visit, one of the bigger pieces of work that we did that was not necessarily patient-facing work was to work with coding. So we realised that some of our data as the national group were pulling it didn't necessarily reflect the service that we thought we were delivering. So one of the projects that we did as a group was to work with coding to have a look at why our day case rates weren't what we thought they were, why our operation keyhole rates, minimally invasive rates, weren't what we thought they were. And actually we unearthed the fact that we'd been coding things incorrectly. So it was a huge relief that we were able to correct that. And as a consequence, we're really excited that the next round of data assessment will be an accurate reflection of what we do. And we're really hopeful and confident that it will be a good reflection, across the region. It was great to welcome the GIRFT team in. It was lovely to do that, within our senior trust team as well, where we could talk through this patient journey. We really enjoy the fact that we are heavily patient-centred in our department, and all of the incremental changes that we've been making, we hope, have enhanced care for the women. But actually they've also hugely increased our satisfaction as a group in that we know we're delivering the best care that we can. We're not perfect. We've still got a little way to go. There's always opportunities to improve things further. And actually having organisations and groups of people like GIRFT coming in making us reflective, making us look at our data, making us look at what, how we deliver the service is a real strength, and we should welcome them to come back time and time again.
Does the network play a key role in sharing the experience that you're learning, and do you share that across the region?
So I don't think the networks share it directly, and that there's not a report published as such, but as chair of the Alliance, we would certainly bring back that learning to the meetings that we have and discuss it in an open forum, particularly if departments are doing novel things that work really well.
How has working collaboratively across the region benefited gynaecology as a whole?
So a great example of bringing together the team across the region is actually some of the work that we've been more recently doing within cancer. So we recognised that there was a high demand on specialist services for tertiary level cancer care for women, and that's traditionally been delivered across just 2 hospital sites in the north of England. And actually COVID brought the perfect opportunity for us to rethink that, and we were able to reorganise ourselves as a group into what we now call a managed clinical network, and we've actually brought together all of the hospitals across the north of England caring for women, be that at a diagnostic level or be that delivering surgery, specialist and non-specialist. And we're now working as a managed clinical network, delegating work out to appropriate hospital sites, including Newcastle, and making sure that women get reach surgery in a timely fashion. That's been really rewarding. It doesn't come without its ups and downs. Obviously this is a challenging group of patients to care for with challenging needs, but I think with us still on that journey looking for perfection, but we're definitely delivering something that's interesting, and we're really looking forward to trying to echo that in the benign setting. Perhaps there's different ways of working where we can delegate different types of cases to different hospitals depending upon facilities, depending upon capacity, and of course the workforce. I think now is the time for us to work in a more dynamic fashion.
I think another good example of collaborative working is the CDC, which opened at the Metro Centre.
And that's Community Diagnostic Centre.
That's right. And we've submitted a pathway which would allow women with unscheduled bleeding on HRT to be referred directly from the GP and avoid the stress and upset of being referred to a cancer clinic. So it's kind of streamlining unscheduled bleeding via the community. They don't have the stress of having to come into a hospital and have the worry of being told you may have a cancer and you're on a cancer pathway now. They're still assessed on an urgent basis through ultrasound in the diagnostic centre, and the result goes straight back out to the GP without ever reaching the hospital. If at that point they're identified as having a concern, then they are then referred into the hospital. So we're anticipating that will reduce the stress in patients, but also reduce the waiting times for our cancer clinics.
And it's fascinating. I've actually been up to the CDC myself, which is based in the Metro Centre, and I can see how brilliant that is for women in order to be able to access that facility by local transport links whilst they're doing their shopping, etc., etc. It's really convenient for the women, and the facilities there are outstanding. We're really proud to be involved with that from a gynaecological perspective, and I think the possibilities are endless.
And we've previously recorded an episode with the Metro Centre Community Diagnostic Centre, so feel free to go back and listen to that episode just to hear how that is helping the region and the community. Finally, how does the Provider Collaborative play a role in all this?
So I guess it provides a mutual support framework which the Foundation Trusts have all signed up to in 2023, which essentially facilitates the flow of patients between hospitals so that patients receive the best care for their condition in the right place and hopefully at the right time. I believe they have weekly coordination meetings which try to address the longest waiters in the region. And as a collective, as a result of these meetings and redistribution of some of the patient pathways and work, it's resulted in our 18-week performance within the region being around 10% better than the rest of the country, which is something to be proud of. There has also been a strong focus on improving the data within the region, which we know is sometimes, when we've examined model hospital and national databases, is sometimes not a fair reflection of the services that are delivered. So it's about going and interrogating that data and ensuring that it's correct if we're going to be judged on it. The outpatient transformation program and GIRFT initiatives, there's been some work around high volume, low complexity cases and moving to a day case model away from sort of inpatient stays and freeing up hospital beds. And then finally what they do is they bring the specialty groups together and they allow sharing of pathways to improve access and timely care for the population.
I think as a side effect, what we've also learned from our collaborative approach within the cancer setting is that actually bringing teams of professionals together from across the region has huge benefits. Everybody's worked phenomenally hard within the NHS over recent years and recent decades. COVID was a particular stress for us. In bringing groups of clinicians back together actually, really elevates what we're doing, allows us to share experiences, learn from others, and actually it drives quality as well. And I think we can only ever see positives coming from working together, both as a team and for the patients.
Brilliant. That brings us to the end of this episode. Thank you very much, Rachel and Michelle, for joining me today.
You're welcome.
Pleasure.
Thanks for joining us for this episode of the Providers Podcast. Hit subscribe to keep up to date with the latest news and catch up with what we've been up to on our website and social media pages.